Assalamu alaikum, everyone. My name is Dr. Zaineb Daud. I am a graduate of JSMU, batch of 1991. I'm a neurologist who's practicing at Anderson Neurology Medical Center in Meridian, Mississippi. The topic of discussion today is headaches. Headaches affects almost 90% of the general population at some point in their life. It is important to know that the most common type of headaches are the episodic tension headaches, but mostly we see migraines in our clinical practice as well as in general practice. Before we go into detail about the headaches, it is important to know what are the pain-sensitive structure in the head. The extracranial pain-sensitive structures include the sinuses, muscles, extracranial arteries, periosteum of the skull, ears and orbits, teeth and the temporomandibular joint. The cranial nerves, which are the optic, oculomotor nerve, trigeminal nerve, glossopharyngeal nerve, vagus, and the first three cervical nerves are involved. The intracranial pain-sensitive structures are the arteries of the circle of Willis and the proximal cranial arteries, dural venous sinuses and veins, meninges, and dura on the base of the brain. Pain-insensitive structures include the brain parenchyma, ependyma, choroid plexus, and dura mater over the brain. Now, let's look into the pathophysiology of the headaches. Cause of head pain include mechanical, chemical, and inflammatory stimuli or pain-generating neurons. The nociceptive neurons within the trigeminal nerves, vagus nerve, glossopharyngeal, cranial nerve C2, C3, and C4. These neurotransmitters include the serotonin, CGRP, and glutamate. CGRP has been seen to be linked to a lot of migraines, as well as the glutamate, which is important in the cortical spreading depression. As we look at this slide, we can see that the pre-symptomatic hyperexcitable increased brainstem response to the triggers. It causes release of the neurotransmitters such as the serotonin, norepinephrine, glutamate, nitrous oxide, CGRP, substance P, and estrogen. The neurotransmitters then activate the trigeminal nucleus, causing dilatation of the meningeal blood vessels, activation of area prostrema, activation of the hypothalamus and the cervical trigeminal system, which in turn activates the cortex and the thalamus, causing the head pain. The pain pathways in headaches are distributed according to different cranial nerves. The trigeminal V1, V2 division locate the pain on the forehead, orbit, interior and middle cranial fossa up to the superior surface of the tentorium. The sphenopalatine branches of the facial nerve are located on the naso-orbital region. The 9th and the 10th cranial nerves and the first three cervical nerves radiate the pain towards the inferior surface of the tentorium and all of the posterior fossa. This is another diagram showing the transmission of pain stimulus from the trigeminal ganglia all the way to the trigeminal cordalis nucleus and into the thalamus. Now, in migraine, central sensitization is very important. Repeated pain signal from the peripheral nociceptive structures leads to activation of higher order neurons. These sensitized higher order neurons contain pain transmission even if peripheral nociceptive input stops. So the first order neurons transmitted to the trigeminal ganglia, which occurs in the first few minutes, causing throbbing pain. The second order neurons are related to the trigeminal nucleus caudalis, which produces pain in the first 1 hour, causing ipsilateral allodynia. and third order neurons, which cause central neuronal sensitization and cause stimulation of the thalamic nuclei, which occurs in the first 2 to 4 hours, causing contralateral allodynia, meaning normal touch stimulus becomes sensitive to touch. Now, the headaches have been divided into 3 different categories called the primary, secondary, and the cranial neuralgias. This is according to the International Classification of Headache Disorder, 3rd edition. The primary headaches are basically the headaches which do not have an underlying cause. Secondary headaches basically have some underlying structural or abnormality which is responsible for producing these headaches. And the cranial neuralgias and the central and primary facial pains are the third category. In the primary headaches, there are 4 main headaches, which include the migraines, tension type headaches, cluster headaches, and other primary headaches. Migraine headaches are seen in about 30% or 12 to 14% of the cases, but we see them mostly in our clinics. It is a common disabling primary headache disorder, affects about 10 to 15% of the general population. Female to male ratio is 2:1. It accounts for about 20% of all the headaches in adults, 1% of chronic migraines. The frequency is about 1 to 2 headaches per month. Mean duration is about 24 hours if not treated. 10% always present with aura. The usual age is between age 15 to 35, and there's a strong family history in about 70% of the cases. Migraine without aura is the most common form of migraine. It is a clinical syndrome which is characterized by headaches with specific features and associated symptoms. To diagnose migraines without aura, you need to have at least 5 attacks of headaches. Each attack normally lasts between 4 to 72 hours, is associated with either unilateral location, pulsatile quality, moderate to severe pain intensity, and aggravated by and normal routine physical activities such as walking or climbing stairs. During a headache attack, patient may present with photosensitivity and phonophobia or photophobia, nausea and vomiting. If these headaches are present for more than 15 days a month for 3 months, then these are called chronic migraines without aura. Migraines with aura are previously called as the classical migraines or complicated migraines. These are recurrent attacks lasting minutes or unilaterally fully reversible visual, sensory, other sensory nervous system symptoms. For this, it is important to note that you only need to have 2 attacks, not 5 attacks, and 1 or more of the following fully reversible aura symptoms are present, which include visual, sensory, speech, motor, brainstem, or retina. Of these, the visual auras are the most common auras, in which a patient may present with a positive aura or negative aura. The positive aura is like a visual scintillation with squiggly lines or looking through water, or a crescent moon which has wavy lines moving across your visual field. A negative aura may be a black scotoma. At least 2 of the following 4 characteristics are needed: that the aura should gradually spread over 5 minutes, can last for about 60 minutes, and usually one aura should be present unilaterally, and it is followed by headache within next 60 minutes. For chronic migraines with aura, you need to have at least 15 days of headaches for 1 month, more than 3 months at a time. Out of this 15 days, 8 of these need to be migraine headaches. Migraines can also have some complications. Few of these are status migrainosus, when a patient may have a delayed attack which may last for more than 72 hours. Persistent aura without infarction, in which the aura symptoms persist for more than 1 week without any evidence of infarction on the neuroimaging. And migraine aura triggered seizure, when a seizure is triggered by an attack of migraine with an aura. Now, there are two specific population of patients we are going to consider in our presentation today. These are the migraines in women. It is important to know that migraines are 2 to 3 times more common in women than in men. It is most likely related to hormonal association with change or fall in estrogen level. 14% of women experience migraine associated with menstrual cycle 2 days before into 3 days into the menses. Risk of migraine increases 10 times in women on oral contraceptive. Another thing to notice is that half of the patients who experience migraine during the pregnancy and after menopause, the frequency of those headaches improves. The second population of patients is the pediatric population. About 10% of children between the age of 6 to 20 present with migraines. Normally, there is a delay in the presentation and diagnosis by almost 5 years because the symptoms may vary and may not be classical for migraines. Less than 12 months, patient or child may present with head banging. Between 1 to 5 years, they may look ill, may have abdominal pain, poor sleep, or irritability. Between 5 to 10 years, they may have headaches, but may also complain of abdominal pain, stuffy nose, and diarrhea. The distinctive features include attacks which are shorter, so they can last between 2 to 4 hours. Headaches may be bilateral instead of unilateral. Few aura, more prominent nausea and vomiting. They may also have more symptoms like abdominal pain, dizziness, and muscle spasms. There are certain migraine categories which include infantile colic, which is seen about 10% of the babies, which are called the colicky babies between third and fourth month. Babies may cry for 3 hours, for 3 days a week, for more than 3 weeks without any relief or any cause. Alternating hemiplegia of childhood normally is seen before age 18 months. There are episodes of unilateral muscle weakness lasting for minutes to days. Long-term learning and behavior movement disorders are seen. Paroxysmal torticollis is between 18 months of age to 3 years. Patient has head tilt lasting for hours to days, may have ataxia and vomiting. The thing to remember is that the head tilt can be corrected. Abdominal migraines are seen mainly in patients between the age of 3 to 10, complaining of abdominal pain and nausea. They may not have headaches at all. Benign paroxysmal vertigo of childhood is seen between age 3 to 6. There are normally sudden onset of spinning and headaches without hearing loss or provoked by movement. Vestibular migraines are more seen in ages between 10 to 16. Patient has a spinning sensation, which may last for minutes to hours and may or may not be associated with headaches. Now, for the management of the headaches or the migraine, it is very important to understand the history as well as the disability of the patient. There are a lot of different disability assessment scores or scales. The one which I'm presenting today is called the Midas scale. This shows how to assess the intensity of the headaches or as well as the disability of the patient. And depending on what the scoring is, the patient disability can be graded from grade 1 with minimum disability to grade 4, which is severe disability. The treatment of the migraine will depend upon the disability level of the patient. If a patient is presenting with mild migraine, Then over-the-counter medication such as Tylenol, Motrin, or paracetamol may be helpful. On the other side, if the headaches are severe and incapacitating, they may need more intensive and acute treatment. The acute treatment of migraines include the non-steroidal anti-inflammatory drugs, such as we already discussed, triptans, such as somatriptan, rizatriptans, ergotamines. The newer ones are the CGRP receptor antagonists, which are highly effective, and the narcotics, which are used as a last resort. Migraine prophylaxis is normally done in patients who are presenting with more than 2 attacks of migraines per week. Even if they are having a single attack or 1 or 2 attacks per month, and if the attacks are prolonged, lasting greater than 48 hours, they are severe and disruptive headaches. Regularly predicted attacks such as menstrual migraines or presence of uncommon migraine conditions, including hemiplegic migraine, basilar migraine, or prolonged aura. The prophylactic medications include anti-epileptic medications such as Topomax and Depakote or valproic acid, beta blockers, which include the propranolol and timolol. Antidepressants commonly used are the amitriptyline, nortriptyline, and venlafaxine, CGRP monoclonal antibodies, and the Botox. The prophylactic medications normally would suggest you should look at 2 or 3 comorbidities in a patient to decide which medication it would be helpful. If a patient has depression, anxiety, having trouble sleeping, then I would go with the antidepressant. If the concern is weight gain, consider Topomax. If condition is looking into high blood pressure with headaches, beta blockers may be considered. Tension type headaches are the most common chronic head pain syndrome. It is characterized by bilateral tight band-like discomfort. Pain typically builds slowly, fluctuates in severity, and may persist for many days. Headaches may be episodic or chronic. It is important to remember that most of the chronic tension headaches do not present with nausea, vomiting, photophobia, or phonophobia. And it is prevalent in about 30 to 78% of the general population, even though we see only about 5 to 10% of these patients in our clinic, because most of these headaches are episodic and last for less than a day per month. For diagnosis, you need at least 10 episodes of headaches occurring for less than 1 day per month, on average of 12 days per year. The headaches can last between 30 minutes to 7 days, usually bilateral, pressing or tightening, and they are not aggravated by routine physical activity. Most of the time, you do not have nausea or vomiting, neither they may have photophobia or phonophobia unless the headache gets prolonged. The frequent episodic tension headache has the same category, except that you may have 10 episodes, which are occurring from 1 to 14 days per month on an average for 3 months. Then the chronic tension type headaches are 15 days or more per month on average for 3 months. Management of tension type headaches include acute treatment with analgesics, aspirin, non-steroidals, behavioral approach including relaxation therapy. Preventive treatment is included basically for patients who are having headaches more than 15 days per month. Non-pharmacological approach includes proper sleep hygiene, stress management, biofeedback, physical therapy. Pharmacological treatment includes tricyclic antidepressants such as amitriptyline, nortriptyline, but sometimes medications such as the beta blockers as well as the anti-epileptic medications are helpful in controlling chronic tension headaches which are not being controlled by the tricyclic antidepressants. Now let's talk about trigeminal autonomic cephalgias, which are also primary headaches. These include cluster headaches, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks, and hemicrania continua. Cluster headaches, for the diagnosis, you need at least 5 attacks, some which are severe and very severe unilateral in the orbital or supraorbital region. They are between lasting from 15 minutes to 180 minutes, are usually associated with conjunctival injections, lacrimation, eyelid edema, forehead or facial sweating or flushing, sense of fullness in the ear, meiosis or ptosis. Another key thing to remember is that the patient has a sense of restlessness and agitation, which is different from migraines in which the patient wants to sit in a dark, quiet room, while the patient who's suffering from cluster headache wants to pace around. Another thing, cluster headaches are more common in males, while migraines are more common in females. It can happen 1 to 3 times per day. Most of the time happen at night time and often at the same time. The acute attacks can be treated with oxygen. Most of the time we do not have the access to 100% oxygen. Then triptans and DHE are effective in controlling acute attacks. For preventive treatment, antiepileptics, verapamil, and steroids have been found to be effective. Paroxysmal hemicrania are unilateral attacks of at least 20 attacks, which are unilateral, supraorbital, or temporal. They can last between 2 to 30 minutes, associated with conjunctival injection or lacrimation. The key to remember is these attacks can be prevented by therapeutic doses of indomethacin. Then we have hemicrania continua, same kind of headaches which are unilateral, may have conjunctival injection and lacrimation, nasal congestion, rhinorrhea, forehead and facial sweating, ptosis, and eyelid edema. The key to the diagnosis is they are unilateral, present for greater than 3 months, and patient will have a sense of restlessness, agitation, or aggravation of pain by movement. These headaches also respond to therapeutic doses of indomethacin. This chart shows the differential diagnosis of primary headaches, basically migraine, cluster, and tension headaches. The other primary headaches include primary stabbing headaches, cough, headaches associated with sexual activity, exertional headache, thunderclap headaches, hypnic headaches, and new daily persistent headaches. The primary stabbing headaches occur spontaneously as single stabs or series of stabs. Each stab lasts for just few seconds. It can be present all over the head area, right, left, and there are no autonomic symptoms, and they can happen once to many times during the day and are again relieved by indomethacin. The primary cough headaches are associated with coughing, straining, or other Valsalva maneuver, sudden in onset lasting between 1 second to 2 hours, and are normally relieved by non-steroidals. New daily persistent headaches are headaches which are present for most, if not all days. The key to remember this headache is that the patient can recall the moment of the onset of the headache. They may say that I started experiencing these headaches on a Thursday in February at this time. Headaches start abruptly, lasting for more than 3 months. The frequency is equal between male and females. Primary exertional headaches are brought on and occur only during or after strenuous physical activities such as exercise or sex. They normally last less than 48 hours and improve with non-steroidals. Normally, we suggest to these patients to take a non-steroidal such as ibuprofen, Motrin, paracetamol half an hour before doing any kind of strenuous exercise or activity. Primary thunderclap headaches are severe head pain, abrupt on onset, reaching maximum intensity in less than 1 minute, normally lasting for about 5 minutes. The key is to differentiate these headaches from other pathological headaches such as intracranial bleed, cerebral venous thrombosis, or pheochromocytoma. Hypnic headaches are recurrent headaches which occur only during sleep and cause awakening. They can happen for 10 days per month for 3 months. The headaches can last from 15 minutes up to 4 hours after waking. There are no autonomic symptoms or restlessness. Normally begin after age 50 and seen mostly in female patients. In the treatment, it is recommended to give them 2 cups of caffeine before going to sleep or melatonin or to take verapamil. There's another chart showing the differences between the cluster tension and migraines, how they present and what can be the symptoms. Now, the secondary headaches are headaches which are attributed to trauma, injury to the head or neck, cranial or cervical vascular disorder, non-vascular intracranial disorders, substance abuse or its withdrawal, attributed to infections such as meningitis, psychiatric disorder, and then we have benign intracranial hypertension or idiopathic intracranial hypertension. This is more commonly seen in obese females and also associated with hormonal therapy, such as oral contraceptives. Patient will have a generalized headache with blurring of vision and may complain of pulsatile tinnitus. Neurological examination and ophthalmological examination will show papilledema. It is important in these patients to do an imaging study, such as a CT head or MRI, to rule out intracranial pathology. If the study is normal, then we normally do a spinal tap. The opening pressure on these is about 25 centimeters. After removing about 15 to 20 cc's of spinal fluid, the pressure comes down and the headaches improve. Another group of headaches are attributed to low cerebrospinal fluid pressure, which is caused by CSF leakage. Headaches get better while lying down and they get worse upon standing up. Again, the MRI is normally done with contrast, which shows meningeal enhancement. And if we perform spinal tap, the opening pressure is normally less than 6 centimeters. Now, the third group of headaches are called the neuropathies, cranial neuralgias. These include the trigeminal neuralgia, glossopharyngeal neuralgia, occipital neuralgias, and Losar-Hunt syndrome. The trigeminal neuralgia is normally seen after age 50, more commonly seen in women than in men. These are sharp, shooting, severe, jabbing pains. They may feel like electric shock, triggered by touching the face, chewing, speaking, or even just brushing the teeth. Pain normally lasts for a few seconds to several minutes. The patient may have a causative lesion, which may cause vascular compression of the trigeminal nerve. And the treatment usually consists of anti-epileptic medications such as carbamazepine. Glossopharyngeal neuralgia are recurrent attacks of severe pain in the back of the throat, near the tonsils or back of the tongue or the mouth, and sometimes it even affects the talking. It is caused by irritation of the ninth cranial nerve, And medications such as carbamazepine, Neurontin, Lyrica are helpful in controlling this pain. Occipital neuralgia caused by irritation of occipital nerve. Sharp, severe piercing or throbbing pain. It starts in the upper neck and the back of the head, radiates up towards the ear, and sometimes goes up into the eye. Non-inflammatory, non-steroidals, muscle relaxants, anticonvulsants can be tried, and sometimes occipital blocks also work. A rare condition is called the Toulouse-Hunt syndrome, which is because a non-specific granulomatous inflammation of the cavernous sinus. It involves the third, fourth, and sixth cranial nerves, causes severe periorbital sharp headaches. There is decreased and painful eye movement. Treatment consists of steroids. Now, as we are pretty much have discussed some of the important headaches, it is important to understand that some of the headache symptoms can suggest a seriously underlying condition. These are called the red flags or the SNOOP. These symptoms include systemic symptoms such as fever and weight loss. Secondary risk factors such as a patient who has HIV or systemic cancer, so considered METs. Neurological symptoms or abnormal signs such as confusion or impairment of alertness. If the headaches are sudden onset, split second, worst headache of their life, then consider the possibility of subarachnoid bleed or venous thrombosis. Age is also important to remember. If your patient presents with the new onset of headaches after age 50, always consider the possibility of tumor or a mass or possibility of vasculitis such as temporal arteritis. If a patient is less than 5 years of age, then again we will consider the possibility of a tumor. Previous headache history is important. If the patient is having first headache or this headache is different from their previous headaches, there is a sudden or change in the attacks, frequency or severity of the headaches, as well as the clinical features of the headaches. Now, the most important thing in the headache is the history. The duration of the headaches, look into the nature of the headaches, site, whether they are unilateral, bilateral, present in the front, present in the back. How severe are the headaches? Do they start gradually building up, or is it a severe headache in the beginning? Is it a continuous headache or comes in episodes? If it is episodic, how long are the durations, lasting for few minutes to many hours? How many episodes are they having in a week? Whether they have any associated symptoms such as visual scintillations, scotomas, auras, or whether they are presenting with nausea or vomiting. What are the relieving factors while lying down or standing up or taking any kind of medication, staying in a dark, quiet room? All of these factors play an important role in the diagnosis of the kind of headaches a patient is having. Location. Migraine headaches are unilateral in 2/3 of the attacks. Tension headaches are more generalized, either in the front or the back. Cluster headaches may present or localize to the eye with autonomic symptoms. Cervical or occipital headaches start in the back and radiate up into the eye. Giant cell arteritis is normally seen after age 50, localized to the temporal area, with scalp tenderness or jaw claudication. Then cervical radiculopathy and neck pain radiating down into the shoulder or up into the head. Intensity of the quality of the headaches also has to be checked. whether the migraines are throbbing or pulsatile. Thunderclap headaches can be because of subarachnoid bleeds. Generalized pressure headaches consistent with tension headache. Meningeal irritation causes generalized headache with neck stiffness. Early morning headache, which may last for a few minutes to hours upon getting up, may be associated with an intracranial lesion or a mass. This is common type of headaches, the last slide in my presentation. Thank you so much for letting me be a part of this great presentation, which all of you have been doing. This was just a small synopsis of headaches. We can also go into the details about the treatment and the diagnosis of the headaches, which can be another presentation. Thank you again for everyone who has helped me in making this presentation. Allah Hafiz.